Hey, everybody, this is Anish. I think we got a reasonably good number of folks who've signed up, and maybe a few more may join us as we get started. But there is just so many exciting things to talk about that hopefully we'll get through some of it as people dial in, but then have some room at the end for conversation. I am Anish Chopra, and very honored to be here today to share my take on the Blue Button Developer Conference 2019, hosted by the White House on July 30th. And the key point I want to convey to you is that there are some specific announcements that took place that might have opportunities for anyone on this call to participate. And so the goal is to make sure that you all are aware about what was covered and that you have some understanding about the possibilities because they're all pretty exciting. And you'll hear from me as we go through this, what a fun journey this has been to see what is essentially not only a bipartisan, but also a sort of a national movement to getting healthcare right, and certainly taking the steps we need to take on the data side to make healthcare better. So why don't we dive right in? I'm going to start with a little bit of the summary. This is the second annual developer conference that's been held at the White House. I will say, as a point of personal, maybe I wouldn't say embarrassment, maybe a slightly, funny comment, which is, I think the Trump team wins the prize for having the first developer conference in the White House. We obviously had a lot of focus on code-a-thons and challenges and prizes, but to actual bring developers to the White House, I must say that was a pretty cool idea. So I applaud the White House Office of American Innovation for having done so. And this second annual conference was chock full of both public and private commitments. The official press release issued by CMS, which was the primary host alongside the White House, focused on an initiative that they've launched called Data at the Point of Care, a pilot project. And I'll say a word about all five of these throughout the presentation, but that was the main announcement, if you will, from the government. In addition, a number of the stakeholders from the cloud vendors updated the public on what they've been doing for the last year. The first BBDC, 6 of the major cloud vendors made a clear commitment to not compete on standards, but rather to unite and collaborate. So we're not going to have a Betamax VHS problem as we modernize the infrastructure, that we're going to work towards FHIR APIs as the bedrock foundation. And I'm very proud of that community that came together and made that statement. Third, I have the honor and privilege of serving as co-chair of the Karen Alliance, and I believe and hope Ryan Howells may be on the line, and people may have questions for him if he is. Ryan and a crew of amazing people from Laurent at Cambia and Heather at Humana stood on stage and made just an incredible set of announcements around not just the availability of a new FHIR implementation guide. This one focused on health plans that can release claims data to consumer designated apps. But perhaps more importantly, the 20 or so organizations that committed to real world testing. Fourth, the similar spirit, HL7 and ONC stood on stage, and with an incredible assist from one of our Care Journey members, Shafiq Rob, launched the coalition to test out the new bulk FHIR standards with another maybe a dozen or more organizations named. And then last but not least, a couple of federal agencies shared a few remarks and opportunities that could also be useful for folks as early as today. So we're going to go through all 5 of these. And what I intended to do in this is just maybe do 2 or 3 slides of context, then we'll get into the 5, and then we'll pull up on implications. And so why don't we use that to dive right in. The context here is that the brand name the Trump team has picked for this project is actually broader than just APIs. The My Healthy Data initiative is a mixture of open data sets, and these regulated and operational APIs. So what did CMS say? Seema Verma in her keynote basically said what we were expecting her to say, which is last year, CMS released Medicare Advantage encounters data for the first time. This is built upon the fee-for-service data that many of you know we work with at CareJourney and is the bedrock of our data products. The Medicare Advantage data has been released. It's in our hands. We've been playing with it. In fact, I'll share some examples of the data on the screen. But the news that Seema made is that Medicaid encounters for the first time will be publicly available in November. So that is really exciting. Obviously, this set of announcements, to be practical and clear, really does come from the work we did in the Obama administration. I'm going to be a little bit of point of personal privilege on that. This movement towards open data was pretty much day one for President Obama. And under the leadership of our HHS CTO, Todd Park, and Niall Brennan at CMS, and a number of other key players, we really built the foundation that is thankfully in this spirit of bipartisanship carrying forward. So fee-for-service data from Medicare, Medicare Advantage encounters, and soon Medicaid. That is to say, data on 135 million Americans will be accessible for research and analytics. On the specifics around MA, for those of you who've been getting some of our preview work, we have focused one particular tranche of research around the roughly 600,000 patients who flipped from Medicare fee-for-service in 2014 to Medicare Advantage in 2015. Now, that cohort of people were generally younger, healthier, and female relative to the overall Medicare population. But what was interesting is that if you fast forwarded their life, what does a year in the life on Medicare Advantage look like? At least as to the issue about their, their composition of illness or their chronic condition status, what you saw is some very interesting jumps. The prevalence rate for morbid obesity jumped about 126% in the cohort of patients that flipped from Medicare fee-for-service to Medicare Advantage. And what was interesting about that was more than half of that jump was on account of a health plan chart review process. That is to say, doctors may or may not document morbid obesity in the billing data. But when someone pulls the charts and evaluates the status of the patient, one can add those conditions, and you can see a range of topics that had that similar growth rate. Another big one that saw a significant increase, the prevalence of drug and alcohol dependence, and other more particular heart condition issues on vascular, as well as traditional heart failure. So the point is, we're going to continue our work on mining the data as CMS releases it in the context of My Healthy Data, but that continues to be an area we are pleased to see that the pace of publication continuing. So on to the Blue Button Developer Conference context. In May, earlier this year, Seema tweeted that this fall, when you're shopping for a health plan, instead of quote unquote doing tedious research on your own, Blue Button 2.0 apps might help you. And she included a hyperlink to the site that CMS hosts roughly 25 approved Blue Button apps. These are applications that consumers can use today to connect to their mymedicare.gov website. Again, as you know, it pulls 4 years of claims history, and it has a refresh token that allows the consumer's data to be updated weekly for 1 more year, unless, of course, the consumer chooses to revoke permission. Last year in open enrollment, Humana, one of our CareJourney members, did go live on their version of that shopping experience Blue Button app. So this was sort of quietly launched with about 10 days left in open enrollment. And the feature function here was that if you were shopping for a drug plan and you wanted to make sure the drugs you've been on historically are on formulary, instead of simply sorting the plan options by premium, if you clicked the link for estimate your drug cost, In the past, that meant you had to actually manually enter the drugs to get the estimate. Today, you can, or I should say last year's open enrollment, you could have permissioned Humana to access your Blue Button data, and they would have preloaded into their calculator your drug history, so you could make a smarter decision. As many of you know, economists have continued to report the average American shopping for a Part D plan spends $500 a year more than they otherwise should on account of the what you would call maybe premium focused selection as opposed to total cost of care estimate selection. So given all of that, as well as the great work that our friends at Apple Health have done to scale the EHR side of FHIR APIs, we're definitely entering an era where consumers are going to be given the authority or I should say the empowerment of being able to collect and organize their data and to share it with whomever they trust. By the way, on another point of personal privilege, another hero of mine, Devin McGraw, who now works at a company called Citizen, released this week what I think is the first real-world evidence of how easy or difficult it is for a consumer to get access to their health information. And I would look to that resource. I'm almost embarrassed for blanking on the URL, but we'll be sure to share it. But certainly if you go to the Citizen website, CIITIZEN, you'll find a link to what is a growing scorecard of how hard it is for consumers to get access to their data. But the good news is, because Apple Health embraced the FHIR API standards, we're starting to see a much more democratized foundation of people capable of pulling their records out to an app they trust. And I love the fact that Apple, like the Citizen example, publishes who is live. And it's amazing. If you go alphabetically, the very first person listed is Richard M. Adams of Family Foot Care of Texas. Now, I don't know Richard M. Adams, and I don't presume that he's got a particularly big IT staff, but he was able to do this. And I also pasted Community Health Systems in Franklin, Tennessee, because they represent an organization that had multiple EHRs. They have Cerner, they have MedHost, they have Athena, they have 106 hospitals and over 4,000 physicians. And they consolidated all of their data into one touch point for third-party applications like Apple. So we're starting to see the policies that we launched in the Obama era that are continuing in the Trump era take root. And this BBDC really sat in this moment of whether or not we can celebrate what's been done so far and or double down on making progress. And I think the double down is where we ended up. So now on to the 5 key announcements. The first of those announcements is the opportunity, frankly, groundbreaking opportunity for doctors to request historical data on their patients for treatment at the point of care. Now, what's important about this is, obviously, one patient at a time Blue Button has been live. Some of you on this call, and we'll get back to that, I think, momentarily, but some of you on this call are participating in the bulk pilot for ACOs. I think Shafiq at Rush is one of the early partners in that effort with 2 or 3 other health systems. And in both cases, there are a few consumer apps that are live, and however many consumers have begun accessing this. In the ACO world, there may be north of 500 institutions that could access the CMS data. In this program, any of the 900,000 clinicians in the country can access and use this data. This is revolutionary. I have doctors who've complained to me that the ACO that they're enrolled in refuses to share the underlying claims data with them. They just give them summary reports. Now those doctors can actually get that raw data about their patients to be used however they see fit without having to go through a middleman. And what's incredible about this is, for those of you who are participating, there's an open source Google group where you can participate. CMS has been wonderful in fielding questions in that forum that everybody gets to see the responses to. By my estimates, there are north of 400 organizations representing physicians who've already put in their request to participate in the pilot. And again, in the spirit of early adopters, they're probably going to pick a half a dozen or so that they're going to work with. And I believe they've already enrolled people in the synthetic data version of the pilot already. Now, the core principle here is it's built on the HIPAA treatment relationship. And what that means is if you have a list of patients in your EHR and you have basic information about them and preferably, hopefully, their Medicare ID number, you can effectively upload a roster and CMS will validate that the patients in that roster do in fact have a treatment relationship with you. Now, I think there are several flavors they're testing. One is that you filed a claim for them in the last 18 months. The second is that you attest that the patient is going to be seeing you within the next 7 days. So I presume a lot of the pilot will be about how do you strengthen the definition of treatment relationship and to make it as easy or automated as possible. So once you submit the data, that is to say the roster of patients, CMS then will give you a token. You can go fetch that token. And more importantly, you can't just load the data in your environment for maybe your IT people to play with. It's only going to be available if the physician can demonstrate that they want to use the information at the point of care. In other words, the power of this program is it'll be one more catalyst to drive FHIR standards adoption, because pragmatically speaking, I believe most organizations on this call that want to take advantage of this service are going to be deploying Smart on FHIR apps so that they can natively deploy in the EHR workflow without making the doctor log into a third-party system. So that'll be an exciting area. Obviously, anyone on this call that has curiosity about participating, feel free to call your Care Journey member services rep. We're all over this. We're excited about it. We'd love to hear from you, what use cases you're thinking about, what you'd like to do with the information. But we think this is a critical idea and far bigger than what we've seen in the market to date in terms of the ability to access and use FHIR resources. The cloud vendors did, in fact, reinstate their commitment. That was wonderful. This is Google, Amazon, Microsoft, Oracle, IBM, Salesforce. This is the picture from Blue Button DC last year. And this year's team put meat on the bone, as they say. All the cloud vendors submitted areas in which they are contributing or actively participating in FHIR standards development, testing, and use. Each of the cloud vendors is building their own strategies on how they're going to help their own customers use these FHIR resources, but they're all pledging to contribute to the global FHIR community. And that's wonderful help that's needed because, as you all know, very little is actually spent on these standards testing and development efforts. Often the government has to pick up a lot of the tab, or truly, truly early adopters. And this really does bring a whole category of partners to the table, in addition to the EHR vendors and the health system and health plan tech vendor partners. I mentioned the Karen Alliance announcement. This probably caught the most actual publicity. So if you were reading up on the Blue Button Developer Conference in the news, you probably read the world-renowned Chrissy Farr, who we all adore in the healthcare sector. She's gone deep on digital health, and she's covered a number of stories that tell us what's happening on the ground, behind the scenes. And she notes in her piece the day of the conference that the large tech companies, in addition to health plans and other stakeholders, health systems, are all coming together to open up access. In this particular article, she's pointing out the commitment made. You can see the stakeholders on the stage, Humana's Heather Cox, another proud Care Journey member, standing front and center, announcing the 20+ organizations that have committed to test the Karen Alliance data standard, the FHIR standard for enabling claims data access to third parties. Important point here. If you all read, and some of you on the line were authors of, your responses to the CMS and ONC rules back in June, it was a bit of a Debbie Downer for me. Meaning, if you read all those letters, and there were probably 1,000 comments to the CMS rule and maybe 500-600 for the ONC rule, the basic message was, we're with you in spirit. This is really hard. We haven't been focusing on this. We need more time. But for Cambia and Humana, at least of the letters that I'd read, the vast majority of health plans who are subject to the rule referenced in this Caron Alliance announcement generally said this thing needs a couple more years. With Ryan's leadership at the Caron Alliance and the whole cast of characters, I will particularly thank Amol Vyas at Cambia, who volunteered their time to basically write a technical specification that could be freely available to any health plan that would meet the CMS requirements that are in the proposed rule to be available as early as January of 2020. Now, while I'm not that confident January 2020 sticks as the final rule, in my opinion, if you listen to the feedback or read the letters in June, you'd probably guess that CMS would punt the requirements for 1, maybe 2 years, given industry feedback, which means 2021 or 2022 consumer application access to claims data. In my humble opinion, thanks to the Caron Alliance commitment that was featured on stage, I'm back in my initial assumption that CMS holds firm to a 2020 date. The time of year may delay to something that looks like the 90-day attestation period, but it probably is a 2020 deadline thanks to the commitment. So it played in my humble opinion, it plays an important role in the rulemaking process. Obviously, I can't speak for CMS or ONC, but my best bet and advice to our members is to anticipate that health plans, certainly MA plans and QHPs and Medicaid managed care. We'll see about Medicaid fee for service. That one may be the hardest to see go live realistically in 2020. I don't think they can even get a procurement out the door by 2020. Remembering my days in state government, just painful. So that was a very big announcement. And what this group said is we're going to test the Caron Alliance CPCDS data standard. We're going to test that in 2019, and we're going to be preparing for production access in 2020. That was a pretty big deal. And I will point out that a number of the stakeholders, there were some big health systems and plans, I should say, like the Blues, Anthem, for example, on the big side, and then the Marshfield Clinic on the smaller side. And so there was really room for everybody at the table. The other big announcement, and in, again, point of personal privilege, something that I cared about a lot, and I hope is pretty important to our family and care journey, is the need to accelerate the testing and deployment of the new bulk fire standard. HL7 and ONC released the official fire bulk data implementation guide, or the fact that it's coming out in printed version, like I think early September, so imminent. And these incredible health systems and health plans stood on stage. We don't have a great picture because we had them stand in the audience as opposed to on stage, so it wasn't as great a visual, but Shafiq Raab at Rush stood there on the White House floor and said, this coalition of health systems working with their EHR vendors, and then he pointed to Sumit from Epic, who was in the audience, and got a little bit of a thumbs up, and said the EHR vendors will support these health systems even before these standards are built into a off-the-shelf upgrade to their EHR, that they could test those standards earlier. And there's a little bit of TBD in terms of the next steps for the group. I think each health system is going to talk to their EHR vendor to figure out exactly how they want to proceed. But the great news is a huge coalition of health systems stood up and said, for plans or ACOs or any other group ID that has a contractual right to the data, will have essentially a bulk fire client they can deploy to pull EHR data, the common clinical data set, effectively nightly from these EHRs. I believe this will be the single most important upgrade to reducing the cost burden of ingesting EHR data and claims data for all of our members. So think about all your IT budgets and how much money you're spending on the data acquisition side. hopefully that number starts to go down, 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 which allows you to reallocate those resources, hopefully, to putting that information to use. I'm also thankful that health plans stood up and said, we want to participate in this. And in many ways, you'd think of this as a reciprocity, where the health systems want to pull the commercial claims data in, and they want to share the EHR data out in value-based care contracts. So I think this is one of the most important areas to watch. I don't believe this is meant to be the end state. That is to say, if you're on the call right now and you want to be a part of this, you're sort of out of the loop. I'm hopeful that the EHR companies, as they develop protocols for how this first cohort can participate, will work to help others who are not listed do so as well. The last announcement, and then I want to spend a few more minutes on context for all of you, and then take questions, obviously. The last announcement, I will call them 3 announcements, 2 from the NIH and 1 from the Agency for Healthcare Research and Quality. First, on the NIH side, there is a larger strategy that NIH has announced to integrate FHIR API standards into whether it be clinical trials, real-world evidence, any other operational use within the NIH. There's sort of a master plan or strategy document that they've revealed that will guide NIH activity. That's very important. It also means that we'll start to see more pharmaceutical firms get more involved in interoperability, in my humble opinion. But also, for those of you on the line that happen to have a little bit of a startup in you, they've announced a funding opportunity for small businesses that incorporate any of these FHIR API standards to support either patient or population level data analysis or decision support. So again, if any of you are interested in that, we'd love to help you. We love seeing startups kind of embrace these standards and benefit from them. And so now there's some capital on the table from NIH to support it. On the application side, AHRQ announced that their pain management app, which was built as a Smart on FHIR app and tested by OCHIN in an Epic environment without any kind of third-party interface fees, that app is now freely available for anyone to use. And an important part of that app is the potential to integrate with your state's prescription drug monitoring program, PDMP. While not announced on stage, it is my opinion that CMS, under the authority granted by the, and I forgot the name of the law, but the law last year that was bipartisan focused on opioids, allows for 100% match for doctors to access the prescription drug monitoring program in workflow, and that particular funding can be used in combination with the deployment of this pain management app, so that there can be, instead of just a lookup table for the patient's substance abuse and controlled drugs history, but actually putting it into the context of a decision support application to help doctors make better choices for those patients suffering pain. And in my opinion, if any of you have an opioid project on the books, you might want to consider pulling down that free AHRQ app, working with your state PDMP to connect that app directly into the hub, and to pursue at the state level that Medicaid match to cover any of the infrastructure upgrade costs that are necessary to bring this to life. And then last but not least, NLM, the National Library of Medicine, a division of the NIH, reiterated, not really new announcement, but reiterated that their FHIR questionnaire app, basically a SurveyMonkey app for assessment data, is available for anyone to use. So if any of you want to incorporate social determinants of health questions or patient-reported outcomes, or take your pick, there's now a free FHIR application that allows you to add whatever questions you want. And the output of that assessment can be written back to the EHR that's compliant under the FHIR questionnaire, as well as to the third-party app that sponsored it, maybe your population health organization or somebody else. What are the implications? So this is now, I think, the real moment of truth, if you will, for how health systems, health plans, ACOs, anyone that wants to publish data or consume data with others I believe this is the centerpiece of what's going to have to happen. I call this the blue bar. We went from Blue Button as a service and Blue Button as a noun. We've got Blue Button as a verb with the Apple Health and all the other use cases. We're now moving from blue buttons to blue bars. And in my opinion, every organization on this call on the IT side should be investing in a blue bar. Now, there are free open source versions of Blue Bar. I think CMS is using an open source version of a Blue Bar, I think from Kong, but I don't know exactly. There are also vendor-led products. As many of you know, I helped develop the Healthcare APIX that is part of the Google Cloud. But everybody from Microsoft Azure to Amazon to Google to Salesforce to everybody will have some Blue Bar capability. And its main purpose, in my view, is to manage what I consider to be the 3 categories of applications that you're going to want to approve to obtain access to the data that is under your control. On the first step, you might want to onboard consumer apps. And those consumer apps are areas like Apple Health and many others. And you might say, okay, we're going to have a developer.xyzhealthsystem.org. Come to our website, request an application token. We'll register your app, give you a key, and the next time a consumer uses your app, as long as they use our username and password for our patient portal, you can pull the data out one at a time. That's the consumer category. That's what's regulated under meaningful use or the new promoting interoperability. That's what CMS is doing with the health plans on this new proposed rule. It's what the Karen Alliance specification would mean on claims data, and the Argonaut project means on the EHR side. But these 2 other apps categories are also to be managed. If you are a health plan or an ACO and you have an app like your care management service and you want to pull data out of the appropriate EHR, whether you're PCP's EHR or a health system that you work with, that too should be an app that you build and register so that you can pull that information legally and contractually tied to the group of patients that you're under some contract to be able to co-manage. And that is what powers the CMS bulk fire for ACOs. And then lastly, that data at the point of care that CMS announced, that is more of a network where I don't have to have a contract with you. I could be a primary care doctor in the community, and I could say to a hospital, I would like to be able to get notifications when my patients are in your ER or discharged. I'm going to bring to you the app of my choice, and I want you to connect that app to your FHIR infrastructure, which will have the purpose and have the responsibility of directing to me for my roster of patients the data. And that CMS data at the point of care functions like a network app. You don't have to be in a Medicare ACO to tap into that Medicare data at the point of care. You just have to submit the roster, CMS has to agree, and then you will pull the data in daily. This is a big deal, and the challenge for most of our members is who owns this infrastructure. CIOs probably have to technically provision it, but they may not be the business owner that drives its use, setting policies and how you're going to accept consumer apps, how you're going to deploy bulk apps from your health plan partners or vice versa, and how and when you're going to choose to support network apps that maybe doctors want or other stakeholders, like your state HIE. I'm a big fan of what Mount Sinai is doing, another proud Care Journey member. And this is Andrew. Andrew might also be on the line. Andrew, this is your handsome face and screenshot from your website. And it's a new role that Mount Sinai launched that puts somebody at the tip of the spear, not to manage the data infrastructure, but to encourage the data's use. And you can hear in Andrew's YouTube video when you listen to it, or you can see in the description of the Mount Sinai Data Office, that among its important mission statements is that if you are a partner of Mount Sinai's, whether you're on the research side, population health side, consumer application side, physician referral network side, that you will want a voice to talk to make sure the applications you trust can be connected to the Mount Sinai infrastructure. And what I love about Andrew's role is that it is governance in its ideal state. Andrew has a direct line to the president of the health system, is not buried in the bowels of IT. And as my brother in arms, Todd Park, often said when it came to the government's open data initiatives, a data set that was added to data.gov is like a tree in the woods that fell. You may not know about it, and so it just sits there inert. You got to actively tell the developer community that the data sets are available. So I remember Todd would get on the plane to go anywhere in the country, even a half a dozen developers were meeting, to remind them of all the data sets that CMS had available to help them do their job. I don't know if I can make the analogy that Andrew equals Todd Park. I love Andrew, I love Todd Park, but I think the spirit of Andrew's role is to take that same mantra of encouraging the data be used across all stakeholders. And I think many of you on this call would contemplate who is the Andrew or the Todd Park in your organization, and whether or not you think about that in the context of the blue bar. I think you got to have the blue bar infrastructure, and you got to have the person driving the engine to encourage the blue button infrastructure, the blue bar infrastructure be used. Last quick areas of opportunity to collaborate. So I have made the analogy, many of you heard me talk about this. Progress on this interoperability journey will take place at the pace of standards development and acceleration. So the sooner we can come together in communities and publish consensus-driven standards models, the sooner we're going to see them tested and adopted in the real world. And hopefully with regulatory power to be scaled up so that we have the long tail of healthcare participate as the early adopters do the heavy lifting. The graphic on this slide goes back to World War I, and in the aftermath of World War I, the American aircraft industry saw its production plummet after the government, the Defense Department, stopped buying planes. There wasn't a United or a Delta or an American Airlines to pick up the slack. Frankly, the airplanes weren't of high enough quality to really sustain that commercial industry. So the industry asked for a bailout, and Commerce Secretary Herbert Hoover went down the road of saying, look, I may not want to take your, I'm not going to bail you out, but what I will do is I will fund the necessary technical infrastructure in an open source manner so that the engineering challenges that stop us from having great planes can be addressed. And on the key standards of engine cowlings and airfoils, this predecessor to NASA was successful in building up the capabilities so that Boeing and Douglas could launch their two most successful aircraft in their era. We have the same standards accelerators in the Argonaut project, in the Karen Alliance, and in the Da Vinci project, so that we can accelerate this in healthcare. On the Argonaut project specifically, we have half a dozen or more published, ready to be implemented Spire specifications. The data query guide, however, is the only one truly published at scale because it's the one that meets the meaningful use requirements for October 1 of 19, the 2015 edition certification rule. But provider directory is available, scheduling is available, decision support hooks is available, even accessing clinical notes is available. That bulk data standard we just talked about, and the social determinants assessment or questionnaire standard. All of them have been published and completed, waiting for people to real world test those standards. Which leads me to my final hope as we get into all of the implications. The hope is that as many of you proceed down a digital journey to complement the work you're doing on practice transformation to move to value-based care, we start thinking about how these digital companions can support the key objectives of value-based care. And the word fiduciary is my comment that we want these applications, these digital partners, to operate in a manner that's in the best interest of the patient, not in the best interest of the person who sponsored the application. So the screenshots here are of the existing Medicare free app called emedicare.gov. It's a mobile app you can download, but it's a dumb mobile app, meaning you can learn about care transition TCM services and there's some explanation about when you may be eligible. But it doesn't actually tell you, oh, we've seen your discharge notification. We know the scheduling slots for your primary care doctor. Please schedule within 7 days because you're eligible for the more advanced TCM service. Or the annual wellness visit, which has this very clear goal of setting a personalized prevention plan for every patient. If I can look at your history and tap into your EHR's care plan, I can learn to see whether or not A, you had the wellness visit, and B, you've got a care plan. And then last but not least, the Medicare Diabetes Prevention Program is now accessible nationwide since May or so of last year. You could have the same phenomenon. In the eMedicare, it tells you what your what your A1C levels must be to qualify. Again, an app that could connect to your lab values, and the network of approved diabetes prevention program partners could tell you that you'd be a great candidate. Here's your voucher. So those are the big items. There's history and context for the policy. There's an opportunity to do a heck of a lot more on implementing and participating in the 5 announcements that came out of BBDC. And there's the spirit and philosophy that we're encouraging. We got about 8 to 10 minutes left. I'd love to open the floor for questions. If you can raise your hand, Ed on my team is going to do his best to field who's interested in chatting or not. If you hit the raise hand icon, we can unmute you and bring on your call. Or if you can chat, that may be another option. And in the meantime, I'll just go back to that main page that had that list of the 5 items. So you had the summary of what took place at BBDC. Anyone with a question who wishes to raise their hand? We may do, I think there may be a chat. Let me see what the chat question is.
Yeah, that's your chat question.
All right, let me get to my chat question. You guys can probably, oh, here we go. All right, can we get a copy of the presentation slides? Absolutely. We will post them alongside a recording of the webinar on our website. All right, Farzad, my man, of all the pieces in the blue bar vision, which ones are what are immediately available? Okay, so this is a great question, Farzad, thank you. Here's my take on the blue bar. I believe the CMS implementation of the blue bar is readily available now. Rush built a consumer-facing app, registered it with CMS, and now Rush patients can authorize Blue Button to pull that data in. I will not be speaking at a school, but I can assume and everyone would gauge that Rush is also testing the bulk fire for ACOs, also provisioned through the blue bar. And Rush may or may not be involved in the data at the point of care project to pull in that more of a network-based status. So that is what's available today, is for health systems to ingest CMS blue bar. Basically build an app connected to the CMS blue bar and then pull that information in for consumer, ACO, or physician direct access use cases. On the bulk EHR side, what I'd like to suggest to you is that the named organizations that are on the real world testing of this project, and you can see them listed here, from, let's go through this list. So we've got Intermountain, Jefferson, Marshfield, MUSC, Mount Sinai, etc. Over the next few weeks, that group of health systems will be communicating as a group and with their EHR vendor. And obviously in this example, the vast majority of these systems are on Epic, to figure out a timeline and a plan to get this commitment realized. I'm grateful that ONC is going to lend some staffing support. So we're going to have basically a kind of a SWAT team working to get this off the ground. Anyone coming to the ONC annual meeting, by the way, there's going to be a bit of a meetup on this issue. I don't know if the timing has been set yet, but it's meant to be that Thursday of the ONC annual meeting. And so I'll make sure we publish all that as we get there. So that's that piece. That also answers Neil's question, my man from Jefferson, who graciously made that commitment. Yeah, Neil, I think what we're going to do is you should definitely continue your bilateral discussions with Epic about next steps. and I'll be working on that kickoff, if you will, for the group, which would be an opportunity. My realistic sense is that over the next 4 weeks, we'll get our act together and get that bulk community off the ground. There was a question about the social determinants of health questionnaire. Who curated the content and the questions? Are they standardized? Well, here's the great news. The wonderful and talented Mandy Cohen, the Secretary of Health in the great state of North Carolina, almost as great as the Commonwealth of Virginia. North Carolina has standardized, I believe, 10 questions for social determinants of health screening for their entire Medicaid program. Those questions are completely free and open source and available for reuse. So you could conform to the North Carolina standard as a starting point. And part of what we're hoping for is organizations in North Carolina to build that FHIR questionnaire and make it available so every doctor, every nursing station, anyone can ask those questions and share the results back with the Medicaid SDOH project. David Cates, my man, another committer from Manifest MedX, the cool kids from California. Are we leveraging FHIR R4? Okay, great question, David. So on the bulk specifications, this has become a bit of a controversial issue because I think the FHIR standards accelerators may not be all on the same page. So let me clarify what is or is not in what standard. EHR vendors are live and in production with the Argonaut project version of DSTU2. That's shipped and in production across many health systems. The majority of Epic sites are live. We're waiting for Cerner to publish its list. It is deployed. I don't expect R4 to be deployed at a minimum until the ONC rules require it, which is going to be 2 years at the earliest from the date of the final rule. Now, Farzad's on the line, so he represents the Office of No Christmas. So it's possible the final rule from ONC may come out around Christmas, which means 2 years from that date will be the requirement for certification that people have an R4 version of the EHR, and who knows when they'll be required to deploy it. So for anybody trying to consume EHR data, I strongly recommend you build your FHIR client app to consume R2, DSTU2, Argonaut project standards. On the health plan side, Ryan's on the line, the Karen Alliance CPCDS is built on the R4 standard. The CMS Blue Button is R3, but CMS has pledged to test the R4 version and will probably be the first to be in production with the R4 version. So for consuming health plan data, pull in DSTU3 if you want CMS, focus on R4, the Karen standard, if you want health plan data from your clinically integrated network, and EHRs stick with R2, DSTU2. Okay, other questions. One big question is whether or not health plans have agreed to use claims data in bulk like CMS is doing. I don't believe any, to my knowledge, any health plan has publicly stated that they're going to make the consumer-facing Karen claims data set available both to the consumer app and the bulk payer, the provider apps. I don't know if they've stated it, but I would absolutely guess if you see a health plan on both the bulk list and on the Karen list, and I'm looking at you, Cambia, Humana, Florida Blue, I'm sure there are others, Anthem, I don't remember exactly who else, but anyway, Marshfield, if you're on both, then chances are you're going to be sharing the same Karen data set in bulk to the ACO partners in your commercial ACO networks, as well as to the consumer apps. That'd be my guess. Steve Lane from Sutter, awesome to have you engaged. Thank you, sir. Let's see, a bunch of other folks. Oh, I'm getting a lot of private messages. Am I going to have to pay $1 billion to my EHR vendor to get the data? I don't know. I don't know. I don't know. That will be a big, big question. The information blocking rule does set what I would call net neutrality payment rules. So if you pay, and I presume you will, that the idea is it has to be as closely tuned to cost and not for rent extraction or competitiveness. So we'll see how the market works. Terry, you've already committed at Ortho Virginia. We just failed to write you on the slide, so shame on me. The amazing Terry Ripley at Ortho Virginia. You are obviously listed on the commitments, so that was my bad. We've got another message. HSPC is doing great work. Yes, we love Intermountain. Awesome people. Excellent stuff. And what is the relationship between the ONC Common Clinical Data Set and the Caron Alliance Common Payer Data Set? Excellent question. The answer is ONC is today regulating EHR data, labs, meds, prescription drugs, problem list, vital signs and the like. The Caron Alliance is really for the health plans that are not today required to use certified technology. So maybe that changes. We'll see how that goes. But the Common Clinical Data Set is really an EHR vendor roadmap. And that is also changing its name to the US Core Data Standards for Interoperability. So you will see a health plan roadmap, claims data roadmap, and you'll see an EHR roadmap. Maybe those roadmaps align. And is there a common data model? Well, if you asked my hero, Atul Butte, the common data model should be OMOP. I have no idea how the world of FHIR and the world of CPCDS converge around OMAP, but maybe that is an answer. I don't know. But yes, we should have a unified healthcare data model. That's an excellent question. Let's see, what else do we got? Right, so Neil's asking a great question. On the direct access to Blue Button data for existing patients, that is absolutely the case. So there are a number of health systems who said, we want to do Blue Button because our cancer center or our orthopedics group would love to get access to the patient's longitudinal data because we're taking on some kind of bundle payment risk. Today, you'd have to do consumer Blue Button to pull that data in. But with the announcement of data at the point of care, those patients absolutely qualify for that data at the point of care program. So Neil, the infrastructure you've built for the Blue Button app, hopefully you can repurpose the bulk of what you've done to pull in the data at the point of care project. And for obvious reasons, as part of the Care Journey family, Neil, we're gonna work on that together. On the other questions, could an ACO send all of their NPIs straight to CMS for the Blue Button pilot? You're mixing two different questions. The first question is, there's a separate Blue Button project for ACOs. In there, you're not submitting anything. CMS has already given you the QAssign file, so you have the member roster. This gives you the chance to do, you could pull in basically what CMS deems you to be eligible for, the attributable and the assignable file. You just simply ask for whatever data CMS is gonna give you and you can pull it in. No need for the roster step. For data at the point of care, you actually have to name the doctor that wants the service, you have to list their roster, and you have to deliver an app that goes into workflow for that health system. Okay, will health systems be publishing a framework for how they will anonymize data for bulk transport for research and development? A great question, Troy. That today is not on anyone's immediate radar. The way I would envision that happening is you probably on the data supplier side would create a separate FHIR server for synthetic or anonymized data, and that you would expose the bulk standards to that synthetic data set. So you might have two implementations of the bulk FHIR server, one that exposes the named data and the other that exposes the de-identified data that you're allowed to share with research and development, pharma, et cetera. All right, we're making, I like this, this sort of chat room based questions. Maybe people are shy, not wanting to raise hands, that's fine. We've got a few more minutes left. If anybody else has questions, Corey is saying that you've got the, Corey has the 10 SDOH questions in North Carolina and willing to share. And obviously, Corey, we would love to, I'll attach that to the link when we post this on our blog. And thank you, Corey, for posting that. By the way, I forgot to mention the whole state of North Carolina, it made the FHIR commitment at the White House event. So thank you very much, state of North Carolina. You did embarrass me in the Commonwealth of Virginia that we didn't do that. So that was a bit bummer, but the first state in the country to do this. I have the file for the screening tool and I will share that. It's actually in the chat room for anybody that wants it right there. Okay, there are other questions around OASIS and MDS data. Oh, the post-acute care world. To my friends, my brothers and sisters in post-acute, please we absolutely have to move those post-acute data elements to FHIR. Ryan is on the line. He may speak if you want to unmute him, but if not, I can just, on his behalf, the Karen Alliance absolutely is working on, with CMS, I might add, on the entire post-acute care data element library and mapping it to FHIR. So absolutely, we would imagine that that project will result in implementation guides. I don't have a timeline on that, but that is an active project. And if you had a interest in connecting, please ping Ryan Howells on the spec. Oh, okay. Yeah, Ryan, do you want to say a word before we wrap up on the status of that? Maybe not. Okay. I think we're nearing the end of it. Okay. Do I see cloud vendors helping ACOs consume bulk on FHIR? I think everybody wants to help everybody. Of course. It would be shocking to me if the, sorry, Ryan, I guess we had a technical muting problem. It's okay. I spoke of Ryan in the spirit of Ryan, which is to say, for those who want to participate in the Karen Alliance Data Element Library, to please ping him, or I can connect you. On the question of cloud vendors and ACOs consuming bulk FHIR, yes, I am very confident EHR vendors, pop health platforms, us at Care Journey, everyone that you know that's been knocking on your door to sell you stuff, everyone's going to come knocking on your door to say, we want to help you do bulk. And so my presumption would be you'll have lots of choices. And maybe the best thing to do is to sort of decide if you're going to build it yourself or partner. And obviously, we would love to talk to you about that. And if you want to partner with a cloud vendor, we'd love to connect you to the ones that we know and love and help facilitate any of that. Okay. I think we are reaching the 2 o'clock hour. You all have been amazing. Thank you so very much for joining. And I will post all of this when I can, probably in the next day or two, to our Care Journey blog. And stay tuned. We're going to be doing more of these webinars as the we continue to see some progress. So thank you all very much and have a wonderful week.